Good evening, everyone. My name is Julius Hobson. I'm Senior Policy Advisor at Polsinelli, and we are outside consultants for APOS. Uh, this evening, we're going to have a webinar on the subject of early and periodic screening, diagnostic, and treatment requirements. And our presenter is Kate Guinness. Kate is Senior Policy Advisor at the Center for Medicaid and CHIP Services at the Centers for Medicare and Medicaid Services in Greater Boston. With that, I'll turn this over to you, Kate.
Thanks so much, Julius. And thank you for being here. I know for some of you, it's an evening hour. For some of you, depending on where you are, it is an earlier hour. So thank you for taking time to be here. Like Julius said, I am a senior policy advisor. My particular focus is on all things kids, which is delightful for me because there are about 38 million kids on Medicaid and CHIP throughout the country. And part of my job is to help think about how to make sure that they're getting the services that they need. And so I'm really delighted to be here. Just by way of background, before I came to CMS a little bit over a year and a half ago, I was at Mass Health, which is the Massachusetts Medicaid program. And before that, I was at Boston Children's Hospital for more than 2 decades, both as a clinician and then as a policy advocate in the government relations office. So I've sort of seen things from the clinical end of things, from the advocacy end of things, and now from the policymaker perspective. And I've been lucky enough to be focused on kids that entire time. I am more than happy to take questions. They would have to go into the Q&A. It's a small group, but we don't have a way to convert this out of the webinar style that we're in. So we're gonna depend on the Q&A. Please feel free to put things in there. I will try to answer them. If I can't answer them, I will take them back and see if I can find an answer to them. I'm gonna start sharing my screen. And what I'm going to be sharing today is a set of slides that actually were presented to states. CMS has what we call all state calls. First, can I just make sure, Julius, can you give me a thumbs up that you're seeing my slide? Yes, okay, great. So we have calls for states, and this was sort of the first on the day that the show letter came out, was the first slide deck that we used for states. So it is publicly available. I intended to do that so that you all can have it. We will share it. I can also put the link to Medicaid.gov, where all of the all-state calls are actually can be found, should you be interested in knowing more. So, and I will say the following, this show letter, so a state out, there are two different, I'm going to assume that you all are not Medicaid experts, which I think is probably that you're kids' eye experts, but maybe not Medicaid experts. So I will say the following, there are 2 different ways that Medicaid can put out guidance for that's sort of not in a regulation. That's not regulation. One is called a state Medicaid director letter, and that goes specifically to the Medicaid director. The other is state health official letter, which is what this is. State health official letter. So you all have probably heard of CHIP. In most states, in many states, Medicaid and CHIP are in the same program, even though they're different programs, but they're managed in the same program. So the Medicaid director may be the CHIP director. In other states, CHIP is actually a separate program. And so state Medicaid director letters would not go to CHIP directors. And this is meant to go for all Medicaid directors. So it's for Medicaid kids and CHIP kids. And so we wanted to, that is why you see the term state health official letter. It was a labor of an enormous number of people with way more expertise than I have in Medicaid. That is why I gave you the caveat that if I can't answer your question, I will take it back and find the person who can, because at CMS, there's a tremendous amount of expertise in detailed expertise in Medicaid, and I do not want to misadvise you. So this is going to be pretty general. If you have questions, if you particularly have questions that are relevant to the work that you do, or you have questions that are specific to your state, for instance, feel free to pop them in the chat. It might be helpful. It often is helpful if I know that I can see the participant list, and it's very helpful to me to kind of know from whence you all come. So if people are comfortable just adding their state to their Zoom name, I think we are all facile at changing our Zoom name at this point. But if folks feel comfortable changing their Zoom name so we can get a sense of where from around the country folks are. If you know anything about Medicaid, if you've met one state Medicaid program, you've met one state Medicaid program. And so it's good for us to just kind of know where folks are coming from. Okay. So the EPSDT really is the cornerstone of Medicaid and CHIP coverage for child health services. And what I will say that I often say is that when I was first at Mass Health, having my first meeting with the executive team at Mass Health, which is the Medicaid and CHIP program in Massachusetts, I got some very wise counsel, which was from one of the attorneys who said to me, "You're in a great position." It was a brand new position to advise. At the time, Dan Tsai was the Medicaid director in Massachusetts before he went to CMCS. And so at the time, it was to advise him on how to do right by kids within Mass Health. And she said, "You're in a great position because kids are entitled, because of EPSDT, to more than commercially insured kids and to more than adults because of EPSDT." And I have sort of held that with me and carried that with me. And then luckily for me, when Dan moved from Massachusetts to the federal government, he gave me a call and said, "Hey, you know that advice you were giving me about the kids in Massachusetts, which there's about 700,000 Medicaid and CHIP kids in Massachusetts. There's 38 million. At the time, there were like over 40 million kids in the country. And would you please come do that federally?" So off I went. But part of it was the fact that this guidance was anticipated to come out. So all that to say is EPSDT is an incredible lever designed to ensure that kids and youth can access the healthcare they need when they need it, so that health problems are averted or diagnosed and treated as early as possible. And that's where there's a huge prevention component to EPSDT. And I know there's a huge prevention component to what you all do, but that's where well-child visits, screening visits, oral health visits, screening for behavioral health, those are all sort of under the umbrella of EPSDT. You have the reference to the statute in the Social Security Act here entitles eligible children under the age of 21, so that means until their 21st birthday, to Medicaid coverage of healthcare, diagnostic services, treatment services, and other measures described in Section 1905A, and we might have some detail about that are medically necessary to correct or ameliorate defects and physical and mental illnesses and conditions, whether or not such services are covered under the state plan. Because you all are not Medicaid experts, and this slide was written for a Medicaid audience, I'm going to go through a little bit of an explanation of this. So you all know what healthcare services, diagnostic treatment, and other measures, right? 1905A is a list of services. There are two lists, one of which is the required services that must be covered, and others are services that are optional within the Medicaid state plan. And the services that are optional for adults, if they're medically necessary for a kid or a child or a youth under the age of 21, the state is required to cover them. So I will use ABA is one that comes up a lot. It's not a treatment that's required to be in the state plan. Some states have it in their state plan. If it is medically necessary for a child, they are entitled to get that service, even if it is not covered within the state plan. And that's just one that I use because it's often top of mind because people talk about it a lot. I think there are probably a number of things that you all do where they are not the sort of very straightforward things that are covered for children. And the important thing here is this correct or ameliorate standard, meaning you don't have to cure. That's what the like correct or ameliorate standard means, is that you're hoping to correct, and you may just make things better for the child. It doesn't necessarily need to be curative. And that's really important because that's very specific. The correct or ameliorate standard is very specific to kids. Moving on. So some of you may have heard that back in, I can't remember what year at the moment. Sorry, it's been a long day. There was something called the Bipartisan Safer Communities Act. And the Bipartisan Safer Communities Act included several things for kids that were, many of which were focused actually on behavioral health services and getting kids behavioral health services in school and in the community. But there was a big piece of the Bipartisan Safer Communities Act that actually required CMS to do several things related to EPSDT. So first was identifying gaps and deficiencies. So how are the states doing? Looking across the country at how the states are doing. Next, providing technical assistance to states to address the gaps and deficiencies. So what's not going great? One of the things that I can tell you is no state does EPSDT perfectly, and lots of states do really great things for kids under EPSDT. And so one of the things we've been doing within the technical assistance is actually using states as who are willing to be examples for other states to talk about what they have done, especially if they themselves have recognized that there is something that is not going well and how they have fixed it. So we both have technical assistance that we provide, and we also pull in states to give state to state technical assistance within our TA. Next is issuing guidance, which includes the requirements, including best practices, which is very unusual for a state health official letter, but including best practices for ensuring children and youth have access to comprehensive healthcare services. So ordinarily, a show letter kind of puts policy out. And in this case, it was even more than that. And then upcoming, there will be a report to Congress on the activities, findings, et cetera. So kind of where are we? And that's something that's due next year. Where are we? What have we done? How's it going? What still needs to be done? So folks are working on writing that report to Congress. I'm going to, so the letter is 56 pages long, which is the longest recorded state health official letter, because if you think about EPSDT, other than long-term services and supports, which are specific services to keep disabled kids in the community and make sure that there's also LTSS for adults, but in this case, I'm talking about for kids to make sure that they can get services that they need. But most other things for kids, the lion's share of Medicaid falls into under EPSDT. So it's a big umbrella. So it ended up being a very long letter. And it was broken, each section that was in the show letter was broken up into policy guidance, effective strategies, and then best practices. The best practices all came from states, sometimes one state, sometimes several states. The states are not named in the show letter, but certainly if states are interested in particular strategies in the show and they come to CMS and say, hey, we want to do that thing that's on page 17, there's a whole team at CMS who wants to engage around how they would do that, including potentially accessing state to state TA. And so those are the best practices. The difference between the policy guidance and the strategies, the policy guidance all comes from either statute, regulation, or other sub-regulatory guidance. So previous show letters, previous state Medicaid director letters, previous technical assistance. So it all ties back to the law. Strategies are how states go about implementing those laws. And then the best practices are examples of like practical examples. The letter clarifies policy implementation. And so we really want the states to be looking at that and thinking about what their requirements are. And there are a bunch of sections of which I'm going to highlight 3 of them today, and I can talk about others. But the first one is promoting EPSDT awareness and accessibility. Now, this is required in the statute. So if you go to if you go and you're looking, because you're a policy nerd like I am, you will learn that actually informing families and beneficiaries and their families is one of the requirements of EPSDT. What does that mean? It means that, for instance, if I were to go to the website of a particular Medicaid program and I were a parent, I should be able to read something that is written in a way I can understand it, that may be in a different language than English, because there are several large populations of folks who speak particular languages, and they've met a threshold. So it may be in multiple different languages other than English. It should be in language that is comprehensible. You should be able to find it on the website or find it in the manual. So that's what the requirement to inform beneficiaries about EPSDT is. We had a question recently that you might find interesting, which is, do you have to use the letters EPSD and T strung together like that to inform families? We're agnostic. Some states do a great job and they never use the letters EPSDT other than to sort of reference it. And other states broadly use EPSDT, explain what it is. We're agnostic about whether it's called EPSDT or not, but you should be able to understand what it is. Additionally, for accessibility, support services like transportation and appointment scheduling are part of the requirement of EPSDT. Those services are only as good as someone can get to them. And so without transportation and without help scheduling, that can often be an issue. Care coordination and case management. We have a big section on that within the show letter. Really making sure that those are part of, again, it's all about how do you got the service over here, and you may have experience as providers or folks in providers' offices, you may have experience where the person keeps not showing, like they're no showing, but it turns out that there's some missing glue there to get them from my child needs, school told me that I need to see somebody because they're not able to see the board, to and actually getting them in the office. So the state is required to actually help put those pieces together. And that's what both transportation, appointment scheduling, care coordination, case management, all of those are sort of part of getting folks actual access, not theoretical access, I'll call it. And states are very, very creative about how they go about doing things like transportation. There's broad, they have discretion about how they implement that policy. We put out a big transportation guide, I think in 23, and states have taken up a lot of the flexibilities and sort of opportunities of how to implement transportation to access services within EPSDT and also outside of EPSDT. That's sort of one of those important things. Next, this is as a policy nerd, kind of one of my favorite parts, which is the requirement to ensure consideration of EPSDT in Medicaid policies and procedures, which sounds like the least interesting thing on the page. But the reality is, from my perspective, what I think of personally is that you have it, if you are a Medicaid director or you're a Medicaid enrollment specialist, or you're thinking about appeals, medical necessity criteria, you're thinking about fair hearings, you have Kate Guinness sitting on your shoulder saying, did you think about what that's like for kids? And you all are pediatric providers, and so you know exactly what I'm talking about, because a lot of things just weren't made to fit for kids, right? And so I know from being a pediatric provider, often it's like, well, that's not really going to work that way for kids. So that's what we want for when Medicaid agencies are thinking about how to do a new policy for transportation, for instance. We want them to specifically think about EPSDT and to make sure that that new policy is considering EPSDT. Or if they're thinking about building a new service like community health worker, or peers, what does that mean for kids? What does it mean in EPSDT as opposed to what it means for adults? So that's why I'm excited about that, because if you have that, then I don't actually need to be in every room, because the policies start to consider the needs of children without my being there. Not that I don't like to be in every room, because I kind of do. And then meeting requirements related to EPSDT and managed care. I'm not sure whether you all know this, about 70% of kids, it might even be higher than that now, in Medicaid and CHIP are actually in managed care plans. Some states have most of their kids in managed care plans. There are still some states that do everything fee for service. But there are a whole bunch of requirements that we have in the show letter related to, if you are going to delegate EPSDT to managed care, are you delegating everything in EPSDT? Are you delegating some of the things? If so, what are they? And what is the state retaining control of, or giving to a different, one example is that some states have specific dental plans, right? So the main plan maybe has everything, but then the dental plan has all of the dental things. And so making sure that that's clear in the contracts and making sure that that is enforced. I'm just gonna keep, I don't see, by the way, feel free to ask questions as I go, so that you don't forget the thing that you wanted to ask. Uh, okay. Next, this, again, all of these topics are near and dear, and I should say, I think I already said, there was such an enormous number of people who worked on this show letter, not just within CMS, but we actually, one of the benefits of being in Health and Human Services at the federal level is that you have access to your colleagues who are mental health experts in SAMHSA, or who are public health experts in, CDC and HRSA, or who are child welfare experts in ACF, or who are thinking about Head Starts in ACF. So we had many voices who helped contribute to make sure this was the kind of guidance that would be helpful. So these are some things that I don't think there's a single conversation when you're talking about access that doesn't then raise the issue about workforce. And for us, when we wrote the show, it's really bringing specificity to the child-specific workforce, as opposed to the general workforce. So states have flexibility around provider qualifications. So who are Medicaid providers? I mentioned community health workers and peers earlier. That's a provider type that is relatively new, but that a lot of states are adding. And those are being used sort of as extenders beyond, in order to sort of reach more kids and families. So states really have broad flexibility to establish reasonable provider qualifications related to fitness of a provider to perform covered medical services, and states can require that managed care plans use network providers that meet these standards. So those are a lot of words to say. States can decide another provider type that's come up a lot of late because of the focus on maternal health disparities are doulas, right? So a lot of Medicaid programs. not a lot. A few Medicaid programs are already covering doulas, and others are exploring covering doulas because of just seeing improvements with doulas um, of maternal health outcomes. So that's just an example of states being able to figure out what the provider qualifications are and cover them. And states can also, this is one, and I don't know if this is something that you all, I know this has come up in the oral health world. And I don't know if this has also come up in the eye world, which is there have been some states that have used incentives to actually encourage where there are no kid providers or almost no pediatric providers of a specialty or subspecialty, training adult providers to be able to do that service. So in the oral health, it's training adult dentists to be able to treat kids, and because there are no pediatric providers. And so that's something where we talk about that and encourage that as one way, especially in places where there are big access problems, to really think about expanding the pool of available providers. And the use of telehealth is there. I think it was in 22, it might have been in 23 that we put out broad guidance on telehealth that was sort of lessons learned from the very quick move to a lot of telehealth during the pandemic. And so we include reference to that. Telehealth, interprofessional consultation, which we put out guidance on that, which says that both the consultant and the consulting doc can both get paid, which was really novel. Like, that was novel policy that says if you need to call and, if you're, let's say, a pediatrician and you need to talk to an pediatric ophthalmologist about a kid that's in your office because you're seeing something, you're wondering whether they, for instance, they need a specialty visit, that consult can get paid for between the two docs seeing each other without the specialist having to see the child. And so that was a big change in order to help access especially pediatric specialty providers. And then I talked a little bit about payment methodologies, but really thinking about how do you get providers to participate in Medicaid, which is, we could have a whole separate conversation about that, but in particular related to serving kids. And next. So the first, you have the sense now of the first part of the show. There was a very robust section that was really about general policies and procedures to make access, to do a good job with managed care, to think about informing, etc. The second part of the show letter was specific to 3 populations, and you can see them here on the page: children with behavioral health conditions, children in foster care, and children with disabilities or other complex health needs. We dug into those 3 populations of kids because they are, first of all, like all Title IV foster kids are covered by Medicaid. And many of the kids with disabilities or other complex health needs, even if they also are commercially insured, they often have Medicaid, especially if they have a disability and have SSI. And then children with behavioral health conditions, I don't need to probably tell anyone on this call about the fact that there is an epidemic, the secondary epidemic after the pandemic of kids with behavioral health challenges, and it gets brought up all the time everywhere, in every room when you're talking about kids and health needs. And so we really focused our attention on how Medicaid can be used to help these 3 groups of kids. So on the behavioral health side, what we really say is that states must have sufficient options of providers. So there needs to be an array of service providers. Medicaid does, like, we do not have the authority to say you must have X, Y, and Z provider type. So we can't, I don't know how well you all know behavioral health, but you can't say you must have in-home therapists and intensive care coordinators and peers, et cetera. But we did very strongly say that there must be an array of community-based services. And part of that is we don't want, part of the entire emphasis of EPSDT is to do things early and to correct and ameliorate, not to wait until kids need inpatient care. And so we spend a lot of time talking and giving examples to states on how they can achieve this sort of requirement, which is there needs to be capacity for screening and assessment. There needs to be care for kids who are demonstrating early signs and symptoms. So that includes the fact that we encourage states to allow kids to have behavioral health care without requiring a diagnosis, which is a revolutionary change from certainly when I was doing behavioral health care for years and years, where you couldn't bill if you didn't have a diagnosis. But we allow for well child care, we allow for screenings, and we allow for, right, all kinds of visits. So really getting behavioral health aligned with what happens in other spaces in healthcare for kids. Community-based services at varying levels of intensity. So that means outpatient therapy is the most straightforward, and then these more intensive services for kids with acute or chronic conditions. Crisis or urgent care, preferably not in the emergency room, but we don't preclude the emergency room. But there are a lot of states that have developed mobile crisis intervention, which is community-based crisis care, which is better than everything's better than going to the emergency room unless you really need the emergency room. And then inpatient care needs to be there, but only really when kids' needs can't be met with community-based services. So we spend a lot of time talking about these things, but that sort of, sums it up. Then we go on to talk about kids in foster care, wanting to make sure that they are getting comprehensive health care as part of their, especially when they're first placed, making sure that they're getting all of their preventive care. And then children with disabilities or other complex health needs, really making sure that their EPSDT obligations are met for those kids. And for the kids who get home and community-based services, often those are in a Medicaid waiver. And we want to make sure that even if you're getting services in a waiver, now waiver services are services that wouldn't otherwise be covered, and the state has asked for permission to cover those services. In some cases, often in the children with disability space, they are covering services because that child would otherwise be institutionalized. And so it's a way to have the kids be getting services in the community that otherwise usually wouldn't be covered. We want those kids to also have their EPSDT services because they're entitled to them. So we spend a lot of time talking about the sort of talking about and clarifying that, to make sure that states understand that, yes, you can do all these cool waiver things, and we love that, and we love to keep kids out of the hospital or out of the institution, but also they need their well child visits, and they need their, screenings, etc. So and I think we might be, yeah. So now we're at the end of the deck, and I'm hoping I'm gonna stop sharing because you don't need to slide this as questions. And I am opening this. So there's a question from Michael Puente. Michael, can you say a little bit about or can you put into the Q&A what your role is? Are you an ophthalmologist? Are you in a practice? I'm just curious. And what state you're from? Maybe I can see that in the list of who you are.
I don't know what state, but he is a ophthalmologist.
Okay, great. Thank you. Thanks, Julius. this is, it's the, oh, there we go. Academic pediatric ophthalmologist in Denver. I was just in Denver for the first time ever. It is beautiful there. Um, uh, so that's a good question of how we objectively determine whether a state is providing adequate access to a required service. So our, and this is another thing that we get asked a lot because we talk about timeliness. And we don't set the standard for timeliness. We allow states to set the standard for timeliness. What I mean by timeliness is how long does it take to get into an appointment? This year, in addition to putting out the EPSDT show letter, earlier in the year, we put out two really substantial rules, neither of which I'm an expert in, but one is on managed care and one is on access. And there are some specifics that around access requirements that will come into being in the next few years because there hasn't previously been. What I would say about the way we look at kids services in general, we have two different mechanisms. One is something called the CMS Form 416, and that is a longstanding congressional requirement that was part of when CHIP first passed. And so we look at the Form 416, and that asks a lot of questions about who's getting what services. And so we can see whether kids are getting their timely, what percentage of kids are getting their timely, well, child visits, dental visits, things like that. So that's on the Form 416. And then we also have a core set. And as of this year, the child quality core set, Medicaid quality core set, is required. And so there's a set of measures, and those include several things that are, I would call them sort of proxies for access, including whether kids got their screenings on time, whether they got their vaccinations on time, whether they had their well child visits, et cetera. So hopefully that answers the question. It's a Medicaid is a fine balance between the fact that states actually have a lot that they have flexibility around, and then the metrics that we're tracking. So thank you very much for asking that question. Will I please explain waiver services? That is a big question. Are you asking specifically about 1915C waiver services or other services? Or are you not sure, which is okay. All right, well, while I'm waiting for maybe an answer from Gwendolyn, so waivers, so I'm gonna back up a little bit. So when I started talking about 1905A services, so there are services that are required and that go into something called the Medicaid state plan. And so any service that is covered under 1905A, that would be in the state plan. It's something we would, it's something we would expect and or require for states to do. States can request waivers. And what that means is they want to do something different that is not something that is covered under 1905A. And there are several different kinds of waivers. That's why it's kind of a big question. And I'm not a waiver expert, but essentially it allows for things that otherwise wouldn't be covered to be covered because the state is going to use those to, and there's different kinds of waivers, but in the 1915C waivers, it's to basically try to keep kids from being institutionalized. And so sometimes those will be personal care services, nursing services. They will have things like respite built into them or other kinds of home-based supports that wouldn't otherwise be covered under the state plan. And those can be one of the things about waivers, unlike EPSDT, if you're EPSDT eligible, you are, and something is medically necessary, you are entitled to it. For a waiver, there can be decisions about who's getting covered, what age of kids are getting covered. For instance, I'll give you a Massachusetts example. our autism waiver only goes up to age 8 in Massachusetts. So it's specifically for the youngest kids, and there's only a certain number of slots. And every year it opens, and it's a little bit like winning the lottery because families really want it. But because there's just a limited amount of budget, there were decisions that were made about that. So there's a lot of information on Medicaid.gov about waivers. So I'm giving you really high level information. And then there's been a lot of attention and paid to something called 1115 demonstrations. And those are where the state is asking to do something very differently than it would be doing if it were if it were done in the state plan. Pay for something different, provide a different service, etc. And what they have to do is they have to demonstrate that it's budget neutral. So we want to do something different because we think that we can provide higher quality care without spending more money. There are many, many, many examples of the state demonstrations that fall under the 1115 waiver. So that was a very broad, answer, but I hope that that at least helps. And if you need more information about waivers, I can definitely get you in touch with and or provide some resources related to home and community-based services waivers, which looks like what the request was. I'm going to answer Michael Repka's question first and then go back up to Michael Puente's question. So as far as I know, there is no difference between the federal match for waivers than so if a state gets 50% or 55%, and I should have started by saying there's shared payment for Medicaid between the federal government and the state, and the proportion is at least 50% that the federal government pays, and it pays more for states where there are a higher percentage of kids living in poverty. So there's a higher federal match when there are more poor kids in the state. So I think it goes up to about 65%, although I could be wrong. So, but I don't believe that there is a difference between the cost sharing for a waiver than for the cost sharing of for state plan services. And then I'm going to back up to, if a managed Medicaid plan doesn't have a pediatric ophthalmologist in network, is there a mechanism to force the plan to add a pediatric ophthalmologist to their network? We are the only provider type trained to manage certain pediatric eye diseases. So I would strongly support Michael, I think who was in Colorado. I would strongly support your going to the Colorado Medicaid agency that oversees the plan, because it's ultimately the Medicaid agency needs to ensure that the managed care plans, if the kids are getting all of their EPSDT services, including their eye care, paid for through the plan is paid a capitated rate per year to take care of that child. If the child needs a service that's not available, then the state is getting paid to take care of, the plan is getting paid to take care of that child. So my suggestion would be, if you have a concern about the fact that kids can't access the ophthalmic care that they need, my suggestion would be to engage your concern, like to bring your concerns to the Medicaid agency about the plan. The other thing that I will say that's in the show letter, and I'm not going to say too much about it because I don't have it up in front of me, but we do spend some time talking about the importance of having specialty pediatric care within your network, including sometimes the need to include out of network and out of state services in order to get kids' needs met. And I know that that is a pretty big deal. Having spent my first chunk of my professional life longer than not longer than I've been at the government work, at a children's hospital. I know that it's a big deal for kids to get access to children's hospitals from working with the Children's Hospital Association. I'm sure the same is true with pediatric ophthalmologists, and the fact that sometimes, there's a question of the adding to the network is one path forward, and the going out of network is the other path forward. And I think we address both of those in the show letter, one of which is says you have to have an adequate network to meet kids' needs. And the other thing, which may also just be a reality, which is they may not have every subspecialist. And so there may be times when the plan has to go out of network, and the kids need to be able to access what they need. So if they need to go out of network to reach you because they have a, particular condition that can't otherwise be treated, then we do speak to that in the show letter.
Kate, the system isn't allowing me to type in Q&A, so I'll just verbally ask mine. What kind of response have you received as a result of the letter? Two parts, from stakeholders and states.
So, stakeholders, meaning advocacy groups, provider organizations, etc.,
Correct.
were pretty thrilled. And not to pat ourselves on the back, but I think I spend a lot of my time talking to the kids advocates. That's like a big chunk of my job. I have like an inside and outside job, right? So I spend a lot of my time. And kids advocates were nervous, I can tell you, before this letter came out, because they were worried we weren't going to get it right, we weren't going to do enough, etc. And what we have heard broadly from a very broad range of stakeholders was really excitement. From states, we have made it clear to them that we don't expect them to pick this up and do everything in it immediately. We hope that all states can look at it and see something where they say, oh, well, there's a thing we could do, and that's accessible, etc. And we are really taking this from a perspective of providing technical assistance. So not, there's our priority is not to punish states for not doing things. Our priority is to help figure out what states need in order to do them for kids, because our priority is to get the services to the kids who need them. And so states have been really engaged in the technical assistance we've been providing so far. We started at the beginning of this calendar year. And I'm sure that there are states that look at this and are pretty overwhelmed because it's so much. And we hope that they are all looking at it to think about what are some of the priorities for kids. I mean, what I have learned is, in addition to what I said earlier, which is like you met one state Medicaid program, but also Medicaid folks are really committed to the work that they do. And so they're looking at this, and they are also protective of their particular state, their particular kids, their particular, right, their needs are very different. And so I think we're seeing very different kinds of engagement depending on the state, but we are seeing a lot of engagement. And we did a webinar for them last week, which was really like a lot of Q&A for them related to this. And they had all kinds of incredible questions. And we had more people on the TA webinar than we had yet, including a lot of folks. So I think states are engaged, which I'm very excited about. I wouldn't be surprised if they're a little nervous, because this is a gigantic piece of guidance. But they're engaged in TA, and like I said, we want to help them. We have a TA vendor. I don't know if I said that. We have a vendor who we're working with, so we can make sure to get the work done. And we will be, this coming year, we'll be putting out a behavioral health toolkit that is sort of I've been calling it the double click into the behavioral health section. We anticipate doing similar toolkits for other areas where really states are like, we need a lot of help. We need we need more concrete examples. We need to really think through how to do this. So hopefully that. So was that one or two questions?
Nope, that was it.
Oh, that was two.
Yeah,
Okay.
one was stakeholders,
Stakeholders and one was
one
state.
was the states. Don't see any other questions, and I'm not sure if Chris has anything he wants to ask.
Can you hear me, Julius?
Yes, I can.
Yeah, hey
Yeah.
Chris.
Hi, Kate. Sorry I wasn't on video, but we certainly appreciate your time, and we are recording this, and we'll get it out to the membership for folks who couldn't be on. So you have been more than willing to answer questions, previous to this. So if we get anything that pops up after the recording, I'm sure we can pass that on, and you'd be happy to answer that if that's possible.
Absolutely.
Great. Well, thank you. And I know that we plan on, utilizing the guidance with our members in individual states who may be having problems, as Dr. Dr. Puente mentioned. There are some states that have very limited networks. And so we plan on approaching those agencies with the updated guidance. And hopefully they will approach you, with suggestions on how to improve
Yeah.
the network.
Yeah.
So thank you.
I mean, I hope that that's the case, and I would encourage the approaching of states. I support the carrot and stick approach. I guess I would say that if you have, and I know that this is always helpful for me when people come and when there are solutions to be offered, like, hey, we actually know of this practice that would join the network if given the opportunity, as opposed to just there's nobody in the right. So I hope that you have success in engaging with the states, and certainly if anything comes up, questions come up, etc., you know where to find me. And I would also just encourage you all. There will be one of the changes in that's I think in the access rule is that there are going to be new Medicaid at the state level, Medicaid advisory committee or council, and a beneficiary advisory. So the beneficiary is obviously beneficiaries, but the other one actually is a broad range of stakeholders. So you might just find out that doesn't go into effect till maybe next July. But as the states, it doesn't hurt to start engaging now and understand what is happening in the space of those advisories, because I think it's always good having, as a former advocate, it's always good to have a seat at the table in an ongoing way, because it helps you to get a well-rounded picture of the things the state's grappling with, and how and when there might be opportunities to get your kind of agenda on the table. So just those all kinds of new opportunities coming.
Well, we are by my clock at 7:59. So we've, as they say, reached the witching hour, and we don't want to take any more of your time. And we really appreciate your presentation tonight. As Chris said, we're recording it so that APOST members will be able to get access to this, and if they have any questions, they'll reach out.
That's thank you so much for having me, and thanks first and foremost to the folks on the call who are serving the kids, because that's really what it's all about.
Well, thank you very much. And with that, ladies and gentlemen, that ends tonight's webinar.
Good night.